going to get started. So welcome everyone to the latest in our Monash Tech Talk series. Monash Tech Talks are brought to you by the Faculty of Information Technology at Monash University, and we invite along a number of illustrious guests each time to discuss issues of how technology is affecting the world. So my name is Jon Whittle. I am the Dean of the Faculty of Information Technology at Monash, and it's my pleasure to be your host for today. And the topic for today is a very exciting one. We're going to be talking about the role that data has played, is playing, and will play in a pandemic situation such as the one that we're experiencing right now. Before I begin, I'd just like to begin by asking you to respectfully acknowledge the Wurundjeri and the Boonwurrung peoples of the Kulin Nation, the traditional owners and custodians of the land on which we are meeting today. And I'd like to pay my respects to their elders, past, present, and emerging. So before we introduce our guests today, I just want to tell you a little bit about the topic that we're going to discuss. So I think one of the things that is quite interesting about the whole COVID-19 pandemic that we've all been experiencing is that it's introduced a whole bunch of new words into our vocabulary. We're speaking in a way that we didn't speak 6 months ago. So we're all now using words like social distancing, herd immunity, Zoom bombing, R number, and my own personal favorite, which is a new cocktail for the times that we're in, the quarantini, which is a mixture of gin and lemon, but with the stipulation that it must be drunk at home by yourself. But probably the word or the phrase that I think will likely become the word of the year for 2020, and the one that is very related to our discussion today, is of course the phrase flattening the curve. That's what all the government regulations have been about. And related to that, this just shows that data has just become such a part of everyone's everyday lives during this pandemic. Even from the very early stages of the pandemic, we started going to websites such as the Johns Hopkins website and clicking refresh at regular intervals to see how many new cases of coronavirus there were around the world. And using such sites to look at maps and curves to see if that curve was indeed being flattened. So data has just become ubiquitous in this time of crisis. And I think more recently, we've seen a shift in the terms of the types of data that people are actually talking about and discussing. So it's not just coronavirus cases anymore. There have been reports, for example, of positive and negative impacts of other types of data. So, for example, there was a report that said that in China, almost 80,000 lives will be saved from reductions in pollution levels. But then on the flip side of that, there are reports that there may be a 30% increase in suicides over the next 5 years. And the Grattan Institute has just brought out a nice map showing by electorate across Australia the number of job losses that have been brought around by COVID-19. So the data is everywhere. It's not just about the number of coronavirus cases, but it's also about the social and economic impacts of all of this as well. And that's really the topic of what today's panel is going to be about. We're going to try and get to grips with, well, how do we make sense of all of this data related to the pandemic? And what can data science and related technologies like AI and machine learning offer in terms of bringing us out of this crisis? So before we go into the questions, I will introduce our speakers for today. So we've got three very illustrious speakers to share their thoughts with you. We've got Bharat Rao, who is a principal at KPMG based in the US. Now, Bharat is a leading expert in health analytics, big data, machine learning, and personalized medicine. He comes very much from an industry innovation background. For example, was responsible for launching and growing the first to market health quality startup, Siemens, which sold to over 300 US hospitals. So welcome, Bharat. We've also got with us today Professor Geoff Webb. Geoff is a professor at Monash University, and he's also research director for the university's Data Futures Institute, which is a university-wide institute focusing on AI for social good in sustainable development, health sciences, and policy and governance. He's also an IEEE Fellow, which he received in 2015, and has received the inaugural Eureka Prize for Excellence in Data Science. Welcome, Geoff. And then we've also got Professor Ann Nicholson, who is a professor in the Department of Data Science and AI at Monash University, and she's also soon to be the Dean of the Faculty of Information Technology at Monash. She is a world-leading expert in artificial intelligence, and in particular, a leading researcher in the area known as Bayesian networks, which, as I understand it, is all about how you can model and manage uncertainty. And I think you will all agree that we've all had to do a lot of modeling and managing of uncertainty over the last 5 or 6 months. So I might start with you, Bharat, if that's okay. And really, this is more of a kind of retrospective question to start with. I've already said, that we've all been looking at sites such as the Johns Hopkins site, tracking data on cases and health-related activity. So maybe you could just kind of give us your thoughts on what was the role of data science in understanding the unfolding pandemic and how to address it?
So, thank you, John. Thank you for inviting me to be here. I mean, the world knows that, the WHO announced in early January that there was this new disease coming out of Wuhan, China. It seemed to be very infectious, etc. But what I guess most people know is that there was actually an AI company called Blue Dot that actually detected the virus almost 2 weeks earlier in late December, and noticing a cluster of diseases, of unusual diseases in Wuhan. But what was much more interesting as well is that they were able to look at flight patterns from Wuhan to other cities and very accurately predict outbreaks and the rise of this. So, the first lesson I would say is that data and AI, there's much more of an appreciation for future pandemics where, the recognition that early intervention is crucial and the use of AI machine methods to scour the information that's available to detect the next outbreak. The next phase, you mentioned Hopkins and, Chime model that was released, was everybody building models, including yours truly, working in fact with Geoff on some efforts to try to build predictive models to help predict the spread of the disease. Turns out that COVID-19 is somewhat unusual. The sort of standard models that work very well for flu and Ebola and other infectious diseases didn't work very well because of the long asymptomatic or pre-symptomatic period in COVID, where once you get the disease, you could infect others. And so, in fact, by the time you saw hospital cases coming in, you didn't have, the disease was already quite widespread in the population. Similarly, when you put an intervention in, like a social distancing measure, assuming it was followed, it's now understood that there's almost a 2-week gap before the impact is spread. So there was a lot around, oh God, help us react to the surge. But now we've sort of shifted to a stage, if I look back over the last 2-3 months, which I sort of call, after react, as sort of the reset phase, where people are going, now what? The surge is over. So hospitals are saying, how do I deal with the fact that I've stopped all elective services and I need to bring people back, use telehealth, etc. So again, data is now being used to model the return of services. Clearly, there's a huge effort on sort of how many people get unemployed, how many people need commercial insurance, go to other insurance. Banks are trying to use the data to predict job losses, foreclosures, so that they can maybe give credit easing so we don't hit the real estate crisis of 2008 where people walked away from their homes. Grocery stores are trying to figure out how to deal with the, how to use delivery. And there's, Amazon has just gone through the roof because they're using data to very accurately essentially give you everything you need without leaving home. So I think data has played a critical role in the detection, reaction, and now as we try to reset to the disease, and it will continue to play a massive role going forward.
Thanks, Bharat. And can you maybe talk to us, can you give us an example of the kind of way that you've seen data being used in helping us to kind of emerge from the crisis?
All right, so it's a great question. So for instance, one of the initiatives which I'm working on, is called Reopen America, where essentially we are trying to help companies come back to work. So the big question is, first of all, is it safe? So what's the community threat level in the area I want to have in my office? So can I not only look at the fact that is the disease incipient, or is it brewing, simmering in the population, ready to impact, but do I have enough capacity to deal with an impact? I don't have enough. So that's one piece of information institution would need. The second set is, okay, what are the measures I need to put in place to protect my employees? There's an app by which is, so there's obviously people talking about digital thermometers and using your data to enter information. There are also AI-based apps which sort of look at you and figure out what your heart rate is, etc. There are indications that those could also be better measures in some sense. And then, so there's the diagnostic piece to help people figure out how to get back to work. And then finally, there's the monitoring piece that says, are you maintaining social distancing? So contact tracing is all the rage. It's all you hear about now. And clearly data plays. I'm talking to some countries who are like, help us implement a contact tracing program where we can use cell phones. But how do we deal with the fact that not everybody has a smartphone and Bluetooth, right? So these are very real. And then how do you perhaps use some other information to figure it out? So there's this whole science that is starting to develop, which Geoff is, of course, which is a very into semi-supervised learning, where let's say we sample the population, we get a few people in whom we get a lot of data, we get some people whom we get a little amount of data, and use that to accurately predict the spread. So there's literally no set of things that are coming. Grocery stores are coming and figuring out, can we start, can we let, whom should we let, and how many people should we let, and what is safe, what's the best configuration to guide traffic, etc. Looking at videos, for instance, to try to figure, are you letting the right number of people in and out? Are you doing what you say you would do? The digital revolution, which most of us thought would happen like in 2030, I think has been accelerated by about several years, probably happening in the next 2-3 years. And every business is using it. And I should have health by itself is a huge example. And I'll leave the question for later to give someone else a chance. But for example, the field of telehealth is going to explode. I don't know the stats in Australia. Pre-2019, in 2019, less than 10% of hospitals and providers use telehealth. We did a survey, and I think something like 80% said they either are or want to use telehealth. So that's another example where you can treat patients who are scared to come in. Now, forget, they don't want to come in, but if they stay at home, their chronic condition gets worse, which makes it worse. So these are just examples in which we see the transformation happening. I still think we are at the reset phase. We haven't yet hit the recovery phase, at least here in the US. It's still reeling, and that's yet to come.
Yeah, so telehealth and in fact health data more generally is a very interesting example, and I guess a lot of this stuff to a lesser extent was happening before coronavirus with electronic medical records and so forth. But I think, as you said, this crisis is going to turbocharge the digital revolution and brought it forward by a number of years. Now, do you see, though, that this crisis has actually led to new examples of real innovation in telehealth, or is it just a case of more quickly applying stuff that we were already doing anyway?
No, there's no question that there's an acceleration. So yes, the EMR revolution, the HITECH Act in the US, or the EMRification of America, was a wonderful step. It was sort of like building the first electric network for the light bulb. But then you had to wait for, washing machines and microwave ovens and computers to come along. So the EMR is in some sense a repository. Yes, there's information. And somehow people said, okay, we will have EMRs, and hey, presto, the quality of healthcare will improve. That has obviously not, it has helped, but it hasn't happened anywhere the extent people would. And that's primarily because all you have now necessarily is a lot more information. So what is happening now, for instance, I was talking with startups who are taking the data and building platforms that, for example, help you identify the most sick patients to triage them and see who can go home. So in the US, you are having examples of automated pathways, so clinical pathways. So for instance, if you want to treat chronic disease, let's say heart disease or diabetes, they're well-established pathways. And now there's a rule, there's a lot of movement, and I'm doing some projects where you're using low-code platforms, which are the rage now, easy to program, configurable platforms, which allow you to implement these routines, built with home health devices that monitor the health. And now what you get is even more data. AI algorithms to detect, for instance, someone's weight has gone up, which could be an indication of fluid retention, and then to proactively set an appointment. Providers are doing things using words which I never thought they'd use. I've heard someone talking about, can you help me do A/B testing? And I looked at them, I'm like, really? And it was like, yeah, I want to figure out whether it's right to call people who are over a certain age, is the best way to call them, send them a text, send them an email, should I do it at 8 in the morning, 10 in the after, 10 in the morning, 2 in the afternoon. I'm sitting there going like, am I talking to a healthcare provider or am I talking to a VC so I think there's this urgent desire to do this. But that's only one piece. AI will allow us, for example, there are a whole host of, there are 110 vaccines in development. Several of them, the design, and assuming Ann can speak more about this because of the field of Bayesian networks, AI is actually being used to design potential vaccine candidates, right? So you're having this. But then if you go to, I'm working with other countries which are, in the developing world. There's this whole notion, for example, can you use lung sounds auscultation, so a stethoscope connected to a phone, for instance, to record the sound and detect, sounds that are similar to COVID. And I hear that maybe with enough recordings, you could actually differentiate between COVID and pneumonia, which is going to be critical, for example, in places like India, if you want to prevent the disease from exposing, so being able to do these diagnoses, etc. There's no end of innovation that's coming. And to close the loop in that, I was actually in a conversation with some colleagues from Silicon Valley, some VCs, and they were saying, well, it seems to be bad. And I said, au contraire, if you want to invest in something today, it just needs to be the following. Take something that either involves someone doing something physical, right? Whether it's going to a hospital, going to a grocery store. I use Instacart as an example. Come up with a way for people to do it with less interaction and more digitally, right? Whether it's a service like Instacart, where it's the case where you can get a very quick diagnosis done of COVID without you having to go to the hospital and get a CT done or wait 48 hours for the nasal swab to come back. That is the new unicorn today, and that's going to explode. So I think there's going to be many, many startups that will come up, not just in healthcare, but in other areas, whether it's grocery stores or manufacturing, etc., where you are going to have an explosion of innovation around this area of doing things digitally. And I haven't even touched the subject of mental health as we get left isolated at home, etc., which is going to also be a real problem. You mentioned that suicides could go up by 30%. So people are working on diagnostic tools to do that. Some university professors I was talking to have a new method with like a 30-second questionnaire that can help diagnose, at least tell to trend if you're trending towards depression, etc. So just amazing stuff coming out all over the world as people are innovating more and more.
That's great. And I think that last point around mental health and the impact of physical distancing is really important, because as we know, what can often happen with technology innovation is that the innovation moves faster than the kind of social aspects or the legal aspects or the ethical aspects can move, and that gets us into problems like Cambridge Analytica. And what you're essentially saying here is that this is going to be turbocharged here because there's going to be a new startup ecosystem around, reducing physical distances with technology, but there are some potential downsides of that as well. We might get into that later. Thanks for that. But I'll move over to Geoff now. So Bharat gave us a great introduction there and mentioned artificial intelligence or AI a number of times, including this blue dot example. You're an AI expert. I mean, maybe you can tell us a little bit about the role that AI played in understanding and responding to the pandemic.
Thanks, John. Very good question. So, pandemic has really moved the world into totally uncharted territory. So not only has there been a totally unexpected health event, but also extraordinary social and economic disruptions and disruptions of a type never before seen. So the big economic shocks of the past, for example, have primarily been demand-driven shocks where people have stopped spending money, whereas now we really have a supply-driven shock where people are unable to spend money because the services simply aren't being provided. So we find ourselves in totally uncharted waters. And if we're to maximise our chances of plotting a good course back to somewhere we'd prefer to be, the better we can understand where we are, the better that we're going to do. So, as you said at the beginning, John, a large part of understanding where we are is accessing the data. And you talked about looking at the Johns Hopkins site and things like the unemployment map from the Grattan Institute. So those are all examples of traditional data collection. So data is typically collected in touch points between institutions of various sorts and the people that they deal with. So death certificates captured in hospitals and morgues, etc. The unemployment benefits captured by the Department of Social Security as people, or the unemployment rates as people seek unemployment benefits. But a lot of the impacts, a lot of the important things are really hidden effects, things that aren't immediately apparent in the traditional touch points that we have. So things that are very difficult to track. So you mentioned that there's concern that there may be a increase in suicide as a result of what has happened, and we don't have data which can directly tell us about that. So one of the questions is what non-traditional, what other sources of data are we able potentially to get at, which can show us how people are reacting and help us to anticipate what the otherwise hidden impacts are likely to be. So one of the things that we're currently investigating in our attempts to understand how the current crisis is impacting the city of Melbourne is analysing social media. So to extract from social media how the mood of people is changing, how the content of their social media interactions are changing. So for example, we're looking at Flickr. So that's, for people who don't know, is a place where people post online and publicly the photos that they are taking. And not surprisingly, there's been a very big change in the types of photos that people are posting. And one of the things we're interested to explore is it possible to extract from that great understanding of how the interests and focuses of people have changed as a result of what's going on? Has their mood changed? And so forth.
And just to pick up on that, Geoff, because I think that's very interesting, because you're now moving away from kind of using data and AI to kind of predict the spread of the virus to much more longer term social impacts. You know, people are focusing on different things, talking about different things. I'm sure we've seen a lot more pictures of food or sourdough bread on Flickr, for example. But do you think those are going to be long-term effects, or do you think they're just short-term things? Or how could data and AI help us to understand whether it's long-term or short?
So this is one of the really large puzzles. So one of the things that we're looking at in this investigation of the impact on Melbourne is how it's going to change public transport. And very early on, so a couple of weeks after strict social distancing had been applied in Melbourne, we did a survey of transport users, and of course they weren't using public transport on the whole because they weren't able to. But their expectation was that they would very quickly be moving back to using public transport exactly as they were previously. So there would be no long-term impacts on their use of public transport. And one of the difficult things about that kind of analysis is that people are often actually not very good at predicting how their behaviour is going to change. So one of the really interesting things is to pick up what evidence we can about how the behaviour is actually changing, and to be able to use various sorts of evidence to map how it unfolds, which then gives us the potential of mapping, sort of forecasting how it's going to continue to evolve. So excuse the background noise there. My dog walker has just returned my dog home.
We might get to see your dog soon. Yeah.
Be careful what you wish for, John.
Just picking up on that point, because I think this, what you're saying about looking at the changing patterns in transport usage are interesting, but it sounds like we're at the stage now where we're really kind of you know, almost being retrospective in that understanding, where we're able to capture data on the movements of people and track that over time, but that gives us more of a retrospective understanding. Can we use things like AI to actually predict how things will occur in the future? There's a question related to this in the Q&A, which is, can we predict the spread of the virus using Twitter activity and web traffic? But I think it's also relevant to the transport stuff that you're talking about. Can we predict in 2 weeks from now or 2 months from now how people will be using public transport? And to me, one of the main challenges there seems to be that, you know, AI is very reliant on large data sets, large historical data sets. It can only learn what it knows, right? But we're in a situation that we've never seen before. So doesn't that mean that AI, you know, Bharat talked about all the wonderful potential applications of AI, but as far as kind of predicting the future goes, it sounds to me like AI can't really help us out because you know, it's something new, and we don't have the historical data from which to learn from.
So there's a distinction made in statistics between interpolation and extrapolation. So much of what we do in standard modelling is interpolation. We're taking like things and inferring what's likely to happen in something which is somewhere in the middle of what we've seen before, whereas what we're looking at now is extrapolating. We've got the start of some trend and we want to predict what's going to happen out into the future, but the future is totally uncharted territory. So there we're really reliant on making assumptions about how the past is going to project into the future, and ideally those assumptions, clearly are going to be uncertain, and so ideally those assumptions are going to include a good depiction of what that uncertainty is, which of course is Ann's specialisation. So maybe she'd like to add something there.
I just also want to jump in that even if our AI models are really not correct because they were built from old data that no longer applies, what they are good at is, as the new data comes in, we can flag the new data as an anomaly. So if the data coming in doesn't match what our models are predicting, it can tell us that our models are out of date and we need to do something else and to look at those other kind of extrapolations and so on that Geoff was talking about. So that's just a general issue as well.
And there's another question that's come up from our audience that I think is related to this, although before I ask it, I just a warning to you all, you know, this whole working from home thing and so forth, I've just had a message pop up from my operating system saying it wants to install updates and it's going to shut down. So I've tried to stop it. If I do disappear, that's why. You'll have to continue without me. But the question, it's related to kind of unstructured versus structured data, and is asking if we'd have had more structured data at the outset, would that have accelerated our review and analysis of findings, which I guess that relates very much to your area of expertise and where you're building these Bayesian networks, these models of what the world might look like, and then I guess trying to kind of marry that up with unstructured data that comes in. Maybe you can comment on that.
It really, I mean, we've talked about the broad scope of potential of AI and data science in many areas. So structured data is really useful when you already, you kind of know what you're looking for, which might be the diagnosis of a disease or a particular impact or a particular, outcome of a particular patient. So structured data in that sense is what we collect in medical records and so on. And, the fact that we even have it structured means that we've identified that it's important and going to help us predict or so on. So there's many things in which, particularly in those early stages when we should have been possibly wanting to take actions earlier, the issue of did we know to collect that data and have it structured in a way for those questions? And I suspect we did, because we've known for a long time that pandemics are a risk, and people understand how diseases and pandemics unfold and so on. So, and we collect a lot of that structured data in all those ordinary systems was there. Whether we analysed it in the right way or picked up on it, it's another matter. The broader questions of unexpected impacts and unfolding and future impact of this pandemic on the broader society, the unstructured data then is where there's things and changes that we can hopefully find things that we didn't even know about in those different kinds of data as well. That would be a very general response to that question, but a good one.
Yeah, let's change tack slightly, because we've kind of talked mainly so far on the role of data at a kind of population level. How do we predict transport usage? How do we predict the spread of the virus? But you're doing some interesting work and actually looking at an individual level and how we can better understand the impact of COVID-19 using AI and data for individuals. Can you tell us a little bit about that?
Yeah, so this is definitely at the individual patient level for what we call clinical decision support, really to do the modelling driven by data where possible to help the clinicians who are dealing with patients, and that could be at the GP stage, first seeing patients, or at the hospital admission time, and really to look at and predict about the progression of the disease, the prognosis, to look at individual risk factors tied to that patient and their particular existing conditions, their profile and medical profile and so on, so that we can best deliver the right care. And in particular, now that people are really trialing interventions, treatments, to factor that in at an individual level where possible, really at the coalface of clinical decision support. So I'm involved with a project to both collect that data at that clinical interface and feed it into what's called a data lake these days, then feed it through to some AI models that we're building now, and to use that to do those individual patient level predictions of prognosis and so on, and feed it back hopefully in real time, so it's most useful to the clinicians. So that's the aim of that project, which is a collaboration with colleagues at University of Sydney, Queensland University of Technology, and also with, because it's through the Australian Digital Health CRC, our partners are state and Commonwealth health departments, which is really important.
Great. And related to that, because one of the things that I think is often misunderstood with AI is the role of expert knowledge. The examples of AI and machine learning that we often hear about are where you have a very large classified data set, you put that into a deep neural network and you get some answer out. But I know there's other work going on that is actually looking at how you combine the best of both worlds, so the human expert knowledge as well as the machine intelligence. Can you tell us about that, and in particular where you see opportunities for that kind of AI as we emerge from this crisis?
Yeah. So that really ties into the particular AI technique that I work with and that we are applying in this current project for COVID-19. It's called Bayesian networks, and it's a very technical term. So I want to just kind of pull that apart a little bit for people who are not computer scientists. First of all, they're a network, but they're not a neural network in the same sense that we're trying to build a map of the interactions between the variables in the system, and that might be the patient's background factors and the progression of the disease in them and the symptoms and test results and so on, where we want to build a network that actually is a causal model so that we can see which things lead to which others. And it's really important for medicine in particular, because if we don't have a causal model, we can't accurately model the impact of interventions, the clinical, medical treatment and so on. So that's the network, causal network part. And the Bayesian part is a term really to say that there's a lot of uncertainty in all of these kind of physical systems that we're trying to model, and we use probabilities to represent that. And so what that means is that we're not a rule-based system. We don't give definite answers. We give probabilities of diagnoses or prognosis and so on, which is more realistic and useful for the clinicians. So that's the kind of model. And then the issue is, well, how do you build these models? And this is the challenge in particular of a completely new disease like COVID is, in that we haven't really got the data on COVID, although we're collecting it very fast. But our medical experts really have obviously an in-depth understanding of the human body and how it works and how diseases in general progress through it. So what we're doing is that we're combining the data that we can get access to, but we're working with groups of medical experts to do what we call elicit, to kind of capture their knowledge about elements of this disease and similar diseases, together with what's in the medical research literature coming out, at a massive rate. It's amazing all the things that are being published and that people are investigating. Well, we try and bring them into our model. So there's data, there's expert knowledge, and then there's the general research literature, findings that we want to capture. So that's a kind of an AI method where there's a structured representation. Data's a part of it, but data on its own isn't enough, especially when everything's so new.
Great. I think we're going to segue into the Q&A. There's a question here from Indrajit, probably best addressed to you, Bharat. And you talked quite a lot, Bharat, about the opportunities in telehealth and using AI in healthcare as we emerge from the crisis. And Indrajit is asking, how can small setups like GPs, dental clinics, aged care facilities best prepare themselves for using AI in the future?
So that's a great question, and and I don't quite know what the situation is in Australia, but in the US, you certainly have not all the GPs are necessary. Still, some of them still use paper-based records, right? So that's difficult. But what you can still do is sort of build. In this case, for instance, we're building apps, we're building sort of digital prescription devices that could be used for patients to enter their own information and monitor their own information. The other way is to sort of band together in large groups of networks where, what is going to happen is you're going to get a dichotomy that's going to happen in the world in the next 18 months. maybe longer, because one of the things is even if you develop a vaccine, it's going to take some time before 7 billion people get vaccinated. It's produce enough and transport enough. Those are going to be enormous logistical challenges. So you're going to have COVID and you're going to have non-COVID. And there's going to be a need for treating the non-COVID patients, especially the chronic care, routine care patients who are not getting care. So one of the ways GPs, et cetera, would be using technologies like Zoom to deal with and interact with their patients so they're freely available. In fact, I think there's versions of Zoom coming out and some from Amazon, et cetera, which are actually compliant with medical, are secure so that you don't have any issues with patient privacy when you use the network. So the first thing I would say is embrace telehealth, figure out which of your patients are willing to be treated from home, do that. Then use some very simple AI-based, and talked about decision support tools. A perfect example is for treating chronic care. There are these tools, very simple tools that help you with disease pathways. So very simple, when you're treating a diabetic, you also have to treat their blood pressure, and you also have to treat their lipids, and so it's very easy when you treat someone with a complex of diseases like that to say, I'm going to focus on the blood sugar because it's diabetes. Using these tools allow you to make sure you order the right tests, you get alerted to changes in there. And again, if you use a modern test lab, you will get the results back, which will tell you what values are out of whack, not within ranges, or have gone up from last time. So there's a bunch of things that can be done as some of these providers, these large test labs start to build in these AI prediction methods into their tests, and you get simple decision support tools for online care. It's a great question, right? It's going to be hard, because if there's one thing that I've learned in my 20 years of trying to apply AI to medicine, is that medicine has inertia, right? They change, and it's very easy to snap back. But I don't think we're snapping back again. I think we are in a new normal, or we're not in the new normal, but we will get to a new normal. And here's the second thing, right? I mean, it sounds terrible. COVID-19 is our first global pandemic. It will not be our last. So we need to start working in this way where, the people who are at the very front line of defense, which are the GPs, et cetera, embrace data capture, embrace telehealth, embrace the use of the clinical decision support tools, and the innovations that are coming out to make them easy to use, to incorporate them in the workflow. But that's a great question, right? And it's not going to be easy, because habits are hard to break.
Yeah, there's a related question here from Sharma, which you or maybe Geoff and Ann also want to discuss. But this is about the adoption of these kind of digital technologies in regions where the IT infrastructure may not be so good. So of course that could be kind of regional parts of even Australia, but it could also be kind of developing countries. Certainly one of the worries when COVID hit us was that, how would countries like Indonesia or other developing countries fare when they didn't necessarily have the same health infrastructure that other parts of the world did. And I guess in the future, given that with this move to telehealth and telehealth as the kind of antidote to future pandemics, we're then creating another problem is that, not everybody will have access to the same level of care through telehealth because it will depend on their stage of development. So how can we address that one?
So let me take a first crack, and I'll use the example of India because I've been working with folks in India around this as well. And India is a developing country. You have 1 billion people, and you don't have enough doctors and nurses, especially, people, if you visited India, the cities are great. You get care that's as good as what you'd get in Melbourne or New York. But 70% of India lives in the villages where it's remote. So there's this effort going on. There are these accredited social health activists. These could be men, but usually women who have, a high school education. They are doctors. And there's this notion of trying to use them as digital sentinels, as it were. So give them a smartphone, have training in there that says, all right, if you're with a pregnancy, right? So put these leads in this place, literally diagrams telling you what to do, measure this data, plug it into the phone. It goes back. You have, if they have connectivity where they are, you can get an instant diagnosis as it goes to the cloud. I mean, these are some of the amazing innovations you're starting to see. I spoke about how, again, you don't need a medical degree to take a little stethoscope and plug it into your phone or into another device and put it against someone's chest to measure their lung sounds. And that, in fact, doesn't even need cloud connectivity. That algorithm that processes that sound actually sits on your phone. Not related to COVID, there's this amazing app. There's this deadly disease called rheumatic heart disease, where essentially it's not very common. It's like about three children in 1,000, so it's small percentage. Essentially, you grow up to have severe heart problems. It's the result of having had strep throat, and not having treated with antibiotics, and you get a heart infection, and your heartbeat sounds as if lub dub goes lub dub dub lub dub dub. It's actually trivial to diagnose with this. What you need, you've got 1 billion people, is somebody to go put the phone against their chest, literally record it and do that. So I think there's this tremendous innovation that is going to be accelerated, because you're going to have in these developing countries a need to rapidly diagnose COVID, or rapidly track people, do contact tracing, etc. And how do you do that without a Bluetooth phone, without all that information that you have? How do you do this diagnosis when you don't have enough doctors? And I believe in the ingenuity of the human race that we are going to come up with great solutions, like Ann was talking about and Geoff were talking about. Yeah. And obviously have them weigh in on answers as well.
Thanks.
So can I just add a sort of an extra challenge for the AI side of things, that, if I build a great COVID sort of prognosis model that can sit and be connected to via the internet, so someone can put in their own profile and we can send them back, some sort of, is it COVID or what's your risk factor, which, could be accessed by anyone. There's a kind of a technical challenge in that we have to be careful that we haven't built our model on data that's so different from the person who's applying it. So some things we hope that, we presume at the moment that COVID will mostly progress through human bodies in the same way, possibly with some genetic factors influencing it. But in a diagnostic model, we have to put in somewhere what we think the background rate of infection is in that population in order to get the right trade-off between what the symptoms might be and how likely they are to have it. Really basic thing. So if we don't sort of tailor the model and at least take into account those local factors, we could get the numbers really wrong. We could be, giving bad advice. So that's a sort of a technical challenge where we should be able to take a generic model built here in our first developed world, and then sort of help deliver tools and things to other countries that don't have such access, but we have to be careful how we do it.
Yeah, we've got a question from Dave here that is interesting question, I think. So this, everything we're talking about revolves around availability of data. And so Dave is asking about, where these data sets come from, in particular, if there are data sets that were produced or provided commercially that are not accessible to the general public or researchers that are provided to be valuable in getting some insights. And I think there's a related question around that, which is, how do we share data across researchers across countries in a way that we can all get the best use of that? And even, what is the accuracy of this data? I remember looking in the early days of the Johns Hopkins data and thinking, well, where did they get these numbers from? Because it was, on the face of it, looked like it was incredibly accurate, 300,622. But was it really that accurate? And where does the data come from? How can we share it in a way that's efficient and ethical and provides the best insights? Maybe Anne, you want to take that one.
So I'll start not necessarily talking about the population spread level, but like at the clinical level, because look, medical people are really good at collecting data, and when they're running trials in particular where they want to be testing treatments and so on, they've got very rigorous protocols around how they collect the data and validate it and store it in order to be sure about the outcomes of the clinical trial. And one of the things that's been that I've been learning about as I've been involved in this project is that there's some very large initiatives right now based in various countries where internationally people are starting to share that data that they might be gathering for one trial or another, and actually sharing the data of. And this is separate from just reporting in the literature and people doing meta studies. They're actually talking about combining the data so that other researchers outside of the individual people collecting it get the benefit from it. And it is a bit of a change because usually each clinical trial sets up their own repository for their trials data, and they mine it as much as they can and get the outputs and publish, and then maybe years later people might get access to the actual data, and things are really being transformed under the urgency of the current pandemic. So there's initiatives, the ISARIC initiative based in the UK but with many countries feeding into, and another one called LEOS that we're speaking to people about accessing data. They're based in Germany, and again they're sharing more broadly. So I think that's really positive, but that's really only on the clinical level, but that's obviously an important component around these kinds of situations.
Great, thank you.
I'll just weigh in on that. We are collecting 66,000 data sets actually, which are signals which we're scraping from the web. A few of those we are paying for, but there's actually a lot of data available. When we built our initial models for the US, we relied on data from Italy. There's a lot of data. There are public sites like covidtracker.com, etc. If you go to the Hopkins site, it actually points you to about 10 or 12 sources, and you go to those sources, they point to another 50 sources, so you're getting the data. Jon said not all that data is accurate. If you actually go to the Department of Health website for the state and look at it, it's not always the same, but people are being amazingly good about sharing data. And we've identified something like 2,000 COVID signals that are out there that we scrape, and we have to get it. Now, it's not clean. It's not, if you spend a lot of effort making it clean, it would be great if, and there's, as I said, these sites that are sharing data, which is a real boon to all of us. But there's also clinical trial data, and companies guard that very, very jealously, as Ann said.
Yeah.
They don't necessarily make that available.
Yeah. We're just in the last few minutes. It's this absolutely fantastic question that has come through. So I might just use the last few minutes to ask each of you this question. And I'm looking for a very pithy answer of 30 seconds or less. And the question is this. So how can big data make a significant impact to the new normal era? So if I can kind of rephrase that slightly, what one thing do you think big data will change, or AI will change as we transition to this new normal? And maybe Geoff, will put you into the hot seat first of all.
So maybe if I could reframe it slightly as what change do I wish would come out of this? So I think one of the things that events has very clearly illustrated, as was drawn out a little bit in that last question, is how important access to data is, and how who controls data has great influence on who gets the benefit of it. And a really good example of that, I think, is the data that companies like Google hold about everybody's activity, and so they've been releasing activity reports, which have been extremely valuable, showing how much more or less people are moving. But that is data they're collecting about us, and why is it that they have access to that and we only rely on their goodwill to be able to get any benefit from it?
Great. So the new normal should reset the way that we access data. Bharat, 30 seconds or less. What's the biggest impact big data can make on the new normal?
Everything. I'm not getting everything, but I'll give you a couple of quick examples. For instance, the supply chain, right? We have all this information on hospitals and the impact on their supply chain, but every industry's supply chain is going to be affected by data. I have life sciences companies that are coming and trying to help me simulate how a particular drug's demand, like for multiple sclerosis, is going to be in 2021 so I can line up my production in 2020? Right? Great question, and you need data to do that. Grocery stores want sales data to help distributors identify what are the most important items to ship to warehouses. Banks want to figure out who's going to foreclose or who's going to get employed. I'm working with several US states who want to know what is the impact of unemployment on, because suddenly their healthcare budget, they're going to run out of money. Hospitals want to know if they need to take a loan to whether they're going to make payroll in 4 weeks. There isn't anything in the new normal that will not be impacted, any business that will not be impacted.
So everything changes. And Anne, you get the last word on this. Biggest single impact of big data on the new normal?
Well, this is what I'm hoping is that as we come out of this pandemic and different countries in different situations try different ways of navigating that, getting their economies restarted and with different strategies, that because of the amount of data that will be generated that we can collect and analyze, that we'll be able to really quickly start seeing what works and what doesn't. And it will be a great tool for our decision makers to be far more adaptive. We don't have to wait so long on things that aren't working, and then it'll help us get back to whatever that new normal is faster.
Well, I think that's a great note on which to end. So it remains for me just to thank our panelists today, Geoff, Webb, Ann Nicholson, and Bharat Rao, for a very inspiring discussion, and thank you very much for your insights. I'd also like to thank the Monash Tech Talks team who brought you this webinar today, and also another 5 webinars that have been part of the series. They do spend a lot of time trying to put these things together and trying to do it in a way that satisfies the participants. So if you could please take a few minutes to fill in our post-event survey, we would really appreciate that. There'll be a link sent to your email shortly, and it's also linked in the chat box below. But that's it for today. We'll see you at the next Monash Tech Talks soon, which is on creativity and AI. But for now, I hope you all have a good day, and thank you very much. Goodbye.